The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone. Sharon Kasalainen. I think everyone should be able to hear me. This is the first time I actually thought I would just be presenting and someone would be kind of managing the technology. So it's a lone show today, so keep your fingers crossed everything works out. Matt, our technology guy, if not, he's available, we'll call on him. So I'm going to talk a little bit about our Strengthening a Palliative Approach in Long-Term Care study. Welcome everyone for joining. I'm excited to be able to share some of the work that we've been doing. Tamara Sussman is my co-lead on this program of research. She's not able to join us today, so I'll be speaking on behalf of her as well. We've recently joined up with John Yu and his larger advanced care planning iCAN ACP study. So this is essentially what we'll be moving towards, talking about kind of our next steps with that program. But to give you a little bit of context, I'll talk to you about some of the work we've been doing up until that point. We had our first study that was funded through TVN, or CFN as it's called now. We have finished that and we have some findings to share. Since that project was funded, we went on to secure some additional funding through CIHR to expand our study out to 3 other provinces. We have Manitoba, Saskatchewan, and Alberta, as well as Ontario for that study. And then, as I mentioned before, we've moved into a larger program grant, really focusing more on advanced care planning and how we can build that into our SPA long-term care project. I'm hoping we can save about 15 to 20 minutes at the end. This is usually the part that I enjoy the most, because I get to hear what other people are doing in this area of research, and always get some interesting questions to kind of stimulate our thinking. Hopefully we can get the technology to work. I believe how this is programmed is you'll type in questions into the webinar, and then I can respond to those questions speaking as I am now. Okay, so a little bit of background, which I've kind of already introduced you to. Our first study that was funded from 2014 to 2016, which is really when SPA long-term care came to be. This particular study was a mixed method study where we used focus groups and interviews, surveys, and chart audit data, really any kind of data that we could find that would help us answer our research questions. We had 4 long-term care sites that we considered our cases, and we really wanted to look at, really looking from the ground up, how we could build this program and implement it within each of these cases. And we purposely chose these long-term care sites because they were very diverse. We had profit, not-for-profit, some fairly stable homes in terms of administrative turnover versus not so stable, and we also had a small home and a larger home, and then medium-sized homes. So these were our original SPA long-term care core components. I'll speak to each of these a little bit more in the slides that are coming, but you can see essentially that large blue circle really is the long-term care home itself. And consistent with participatory action research, we saw ourselves, the research team, and we assembled an advisory board, as well as some community palliative care consultants. We really saw ourselves as supporting the long-term care home and really helping them build this program into their current practices. So the first job we had was really to work with the homes to help them assemble a palliative care champion team. So this is very consistent with any kind of implementation science, with the implementation science literature, where you really need this advocacy group on site, not the researchers, but the healthcare providers themselves that work there, and the other staff respect and are comfortable with, and are kind of the natural leaders, tend to be more enthusiastic about the research study. And we wanted to make sure that it was interdisciplinary, because we know in palliative care, you know, an interdisciplinary approach is very much needed. So this champion team really was, I would say, one of the very core components of the program. And we've gotten to know the champion team members very well. We work closely with them, and they tend to be kind of the interface with the research team to the long-term care homes. And essentially, once we're able to build their capacity up, we could step away and not be involved as much as we were initially. Comfort Care Rounds is a concept that emerged in Ontario here with the palliative nurse consultants. I worked closely in some of my previous work with Mary Lou Kelly and Mickey Turner, who was a palliative consultant, really trying to bring these external consultants into the long-term care home to provide some education and support for long-term care staff. There really traditionally isn't a lot of palliative expertise within long-term care staff, so this is a way to help build capacity and help improve resident care. So their paper, Abby Wixon-Griffiths has published, really that spoke to how well these comfort care rounds were run, some of the barriers. Essentially, time commitment, pulling staff off the units was one of the main barriers. We're now moving more towards what we're calling a huddle, so a less formal comfort care round, whereas you just gather staff that are able to come to the nursing station and just have a few minutes to kind of debrief about resident deaths or reflect on current issues related to residents declining. The palliative performance scale, when we first worked on getting this proposal together back in 2013, 2014, this was really the only tool that we could find, and there was some literature that supported its use in long-term care. It's Canadian made, it was developed out in Victoria. So we chose this because we knew that we needed, staff needed a trigger, some way to kind of trigger their thinking that a resident is declining and the care for that resident needed to change, and some decisions needed to be made at end of life. So this was a tool that we used. Staff actually found it helpful. There were certainly a lot of things they didn't like about it, and they adapted it so it was more helpful for their settings. And we used it to trigger family care conferences, really palliative care conferences at end of life. You know, the PPS score we put down as a 30% originally. We ended up moving it to a 40% because we wanted to capture people not so near to death. And then we organized a family care conference to bring staff members, families, residents if they were able, including the physician and personal support workers, to gather around, have some discussion about, you know, what are some of the wishes and goals for care at end of life, and some of the kinds of care planning that they were hoping to receive. It was really interesting to see some of our data over the course of these family care conferences, how we had some research staff sit in on them, and over the course of the conversation at the end, family members were definitely at a much better place, were more comfortable, felt more informed, and more satisfied with care. And the end of life conference, so this is something we borrowed from Deborah Parker in Australia, who had really developed the process for these family care conferences. And included them in her toolkit that was rolled out across Australia. So there's a video, and if you look at the bottom of the slide, it's on YouTube, so you can access it. We used it for training staff so they could get a sense of what a family care conference would look like. Deb has used it to help educate families as well, so they know kind of what to expect before coming to a family care conference, some of the kinds of discussions that may occur in a family care conference. And it's really a nice video, 5-minute video, but captures the essence of what a end-of-life family care conference will look like. One of the things that we developed over the course of our TVN-funded study, out of our what we're hearing from the staff, was that families and residents wanted more information about what to expect across the life trajectory in certain illnesses. So Tamara really led the development of these pamphlets. We worked with some very skilled students as well to help us build them. It went through, I think, probably 10 iterations. We involved experts as well to help us really make sure that what we were presenting was accurate and meaningful for families and residents. These are posted, if you follow this link, they're posted on the CHPCA website. They're available. We've kind of customized them for our larger CIHR grant so that the resources and the information are province specific. So we have specific ones for Ontario, Alberta, Saskatchewan, and Manitoba, given the resources that are local within those provinces. Where we also worked on developing some bereavement pamphlets. These aren't as far along. We still have some work to do with these, but this is on our agenda to work on over the next year, and certainly within our CIHR Physy grant. Similar kind of concept of providing some information, a list of resources, local resources and national resources, and the kinds of questions that family members or residents can ask healthcare providers, in a way giving them permission to ask some of these questions in the right words to use it. So these were our initial findings with our first study. We had, as I mentioned, the 4 long-term care homes. We started out with a total sample of 551 residents. We had staff complete palliative performance scores on all of the residents. We did have a miss 8 residents we weren't able to get scores on, but for the rest of them we did. And then we organized them for greater than 50%, which is essentially, they're early on in the trajectory, not as close to end of life as you would be if you were 30 to 40%, or even more so, less than 30%. We targeted the 30 to 40% and lower because we thought they would be the ones who would benefit from a family care conference the most. And as you can see, that represented 20% of our population, or the number of residents we had a score between 30 to 40%, and then we had just 1% under 30%. So they were the ones that were really close to end of life. We have a diagram here so you can see how many residents we were able to enroll in the study, how many went forward and had family care conferences, and then again, how many of those residents who had the family care conferences or didn't have them in time passed away. It's interesting to see that for PPS scores between 30 to 40%, they tended to live a little bit longer compared to the PPS scores of under 30%, where they died anywhere from 2 days to 2 weeks after having a family care conference. So we did publish a few papers for those people interested in getting more details about this study. Tamara led a paper that was based on the qualitative focus groups and interviews that we held at the very beginning of the study. and there's a reference there that you can access it. I don't believe it's online, but if you need help finding that, feel free to email either myself or Tamara. Essentially, what these focus groups, what we are seeing is the way residents and families conceptualized comfort. They really saw comfort as a very holistic concept, and often didn't speak about dying, but they framed it within this concept of comfort at end of life. Talked a lot about their wishes and fears at end of life, and how their experiences with the long-term care home and the way they had experienced their life trajectory, particularly at end of life. One of the themes that we did hear coming through was residents saying how they didn't have a chance to really grieve the deaths of other residents. And often it was kind of hidden in the long-term care home, where residents would have preferred to acknowledge the death and allow themselves to go through the grieving as well. So this was one of the main findings that we found, and the whole essence of wanting to honor a death, honor a resident's life within the long-term care home came out very strong in this paper. We also, I led a paper looking at our survey data, so we looked at differences across healthcare provider groups, so those being support workers, nurses, managers, and then registered staff as well. And what we did find, we had a fairly good response rate, which was great. A lot of staff completed the survey. And we found that support staff, so the dietary, housekeeping, really had were significantly less comfortable with talking about end of life and felt they needed more training in order to engage in any kind of conversation with families or residents about end of life issues within a palliative approach. And given, they're often the ones that family will come to with questions or, want to talk about some of their concerns, we felt this is a very important gap and one of our goals to work on in our next phase of the study. We also looked at, so this was kind of an interesting, I thought it was interesting anyways, what we did with our baseline chart audit data. So we went across the 4 homes, looked at ER admissions or ER transfers, hospital admissions, and hospital deaths. And we compared that. So we had each of the 4 homes had their own set of data. And then we also had our mean or an average across the 4 homes. And we took, we had a 1-page handout. We took that data back to the home and talked with the champion teams about their perceptions of how they saw their data. So some of the homes had higher ER transfers than other homes, or the average. And we had them reflect on why they felt that their results may be different than the average. And it really was a nice quality improvement activity, but essentially found, so this is the data here, but essentially we found, the homes actually were very receptive to this, even the ones where their chart audit data really didn't look as great as they had hoped it would, but they were very receptive to it and really quite enthusiastic about trying to try to find ways to improve their chart audit or their ER admissions and hospital deaths for the end of the study. Some of the key things we found, certainly the one site that had very low ER transfer talked about the clinical expertise that existed within the home. They would rely heavily on a nurse practitioner that they would bring into the home to help them with difficult situations, which essentially precluded them sending residents to the ER. They were able to keep them at home. A lot of discussion around communication and engagement with family as being one of the reasons they would send residents to the ER, because that's what families wanted. It makes me think perhaps if we had some of these discussions earlier on, that perhaps families would be more comfortable with having residents stay in the long-term care home if they felt more prepared when that kind of crisis situation hit them. Another paper led by Pamela Durapo. She's a PhD student. She looked at the family care conferences and some of the content and processes. So as I mentioned, we had, for most of the family care conferences, we had staff attend to take field notes. We also had some special forms that we used that are adapted from the work that Deborah Parker had done in Australia. So we're able to look at those forms and kind of analyze the data that we were seeing. What we did find, partly due because of the family care conference forms, we were able to kind of prompt staff to look at needs and goals of care in a very holistic manner. So not just looking at physical needs like pain, but we're also able to look at some spiritual and psychosocial needs, and they were well covered in the family care conferences. The forms really provided a way to document some of these goals of care and wishes for residents and families, and these forms were in the chart so staff could see them. Interestingly enough, we found there was quite a few of the residents who had family care conferences. The large majority had dementia. So it made us think that perhaps this population or this group, particularly the family members, felt a need to have a family care conference and wanted to kind of plan out care and make some decisions there. Plus, it could be that we had generally the population in long-term care tend to be, have higher dementia rates, up to 75%. So that could have accounted for the higher proportion. We did hear from families that they felt the family care conferences were helpful and helped them support care planning and communication about end-of-life issues and some of their concerns that they had. And this is probably, I think this is one of our last publications that was just published. I believe this is available online. I'm not sure if it's actually available yet, but it should be soon. I don't see the link here. And this really speaks to the illness trajectory pamphlets that I showed you earlier, and goes through the process of how we developed them. And we actually piloted them in the long-term care homes, and these were some of the results that we found for them. Some of the survey, so we did a survey for people who used the pamphlets. We had them on display at the 4 long-term care homes. We also asked staff to provide pamphlets if they felt a family member or a resident would be receptive, and they would take the initiative to give the family member a pamphlet. And then we had family members, we asked them and residents to complete a very short survey to see what they thought about the pamphlets and if they were helpful. So you can see here 84% felt that the pamphlets helped encourage reflection, made them kind of think a bit more about their family member, where they're at in their trajectory, some of the things, some of their concerns. It helped validate some of their concerns and help clarify what to ask. So there are questions that were worded in the pamphlets to help family members ask these questions that they may have not been able to kind of think of until they saw them listed in the pamphlet. And they found 63% said that it increased their comfort with end of life within a palliative approach. Some of the barriers, there were some concerns for residents and families that some of the pamphlets may help trigger some emotionally unsettled feelings, maybe family members, and that's why we purposely had staff choose the families and residents they felt would be comfortable, because we didn't want to give pamphlets to someone whose staff felt weren't ready to have some of these conversations or start thinking about some of these issues. So our second study, our subsequent study to our TVN funded one, it's called the Partnering Together to Improve Palliative Care and Long-Term Care Homes. You can see we have a very large team. We were able to get some co-funding from provincial partners as well. Lots of enthusiasm for the project, and a great deal of support from each of the provinces to implement this program. So these are provincial site leads. Lynn McCleary and myself are the two Ontario leads. Tamara is, well, she's situated in Montreal, but her sites are actually in Toronto. Abigail with Wooks and Griffiths, as well as Paulette Hunter in Saskatchewan, Genevieve Thompson in Manitoba, and Lorraine Venturato in Calgary. So each of those really led the provincial hub for implementing SPA long-term care at one long-term care home, and really help leveraging some of the external resources and networks that existed within their local community. So our goal is to kind of ramp this up and spread the program to more homes now that we have the program a little bit more well-defined and some resources developed to share. Here's the map in case you didn't know where all of the provinces were. And we did revise our SPA long-term care project a little bit, partly because of some of the work and the learning we did in the first round. So here we actually have the illness trajectory pamphlets that we're able to share at the very beginning of the study. And we're really framing that as more to start advanced care planning discussions, or provide some information for families and residents to start thinking about advanced care planning. The bereavement follow-up, we have the pamphlets that we're hoping to develop a bit more and share. And then the end-of-life family care conferences, keeping them moving ahead once they're triggered with the PPS score. So in Manitoba, it's been quite interesting to see how each of the local communities have different initiatives already going or starting to go. So this is the nice thing about having a cross provincial project. We can learn from one another and see, you know, what things people are doing in certain provinces and how we all might be able to share those. So in Manitoba, they have a comfort care cart and a memorial board that they use in their site. They've had a very good response from staff. They have a champion team set up and really moving ahead with their site in Manitoba. And Ontario, they've had the added advantage, I guess, of having LEAP long-term care training. We had a 2-day training session. This is one base, you know, given it's a participatory action research project, this is one of the things that emerged from this particular site was that they wanted to have some formal education around a palliative approach. So we were able to leverage some resources in order to train the champion team and others with the LEAP long-term care curriculum. We have a bunch of different publications that are, some are submitted, some are still in progress, just to give you a sense of some of the data that's emerging from our larger study. Each of our site leads has led one of these papers, and really, you know, we each kind of came in with a different perspective, and we're trying to leverage the data that we have and share it in publications and presentations as well. We moved on to look, we realized with our first study in particular that there was a real gap with advanced care planning. So we were focusing more on palliative end-of-life decision-making with our family care conferences, but we realized we're missing this whole cohort an opportunity to engage residents and families early on in the trajectory. We were finding by the time we reached them with the family care conferences at the end stage, there wasn't a lot of time to have some of these discussions, and families were in crisis mode and really had some difficult decisions to make. So one of the goals was to kind of ramp some of these discussions back, and so that's been really the focus over the last year or so, is how to have these advanced care planning. What kind of education do we need to have for staff? We are hearing from our champion teams that they really lack knowledge about what advanced care planning meant. So when we started asking them what did they do around advanced care planning, they really weren't even sure what it was. So we realized education and training is key, and also their comfort level to engage in some of these conversations was lacking. They did have the LEAP long-term care training, but they still didn't feel comfortable with some of the communication that was needed to engage with families around advanced care planning. Certainly in long-term care, always an issue with time constraints. They're very busy, and really struggled to take anything new on. So part of our approach is trying to see what they're currently doing and how can we kind of integrate into current practice in a less burdensome way as we can. One of the other issues that it's quite interesting to see the readiness of family and residents to discuss ACP. Often this was raised in terms of other people. So staff would say they didn't feel families and residents were ready to talk about it. Families would say they didn't feel residents were ready to talk about it. And then when you ask residents, they would say they didn't feel like the family, they didn't want to distress the family and have these conversations. So no one really said themselves that they were uncomfortable other than staff for their own skills and knowledge. But I think just a generalized lack of readiness on behalf of everyone. Certainly having administrative support is key, and having ACP tools that are specific to long-term care. We know there's a growing body of advanced care planning tools emerging, but long-term care is very unique and has lots of challenges. So that was one of the things that Tamara and I sought to find a tool that would be appropriate for the long-term care population. We did a stakeholder analysis as well from kind of decision makers, clinicians, researchers from across the country. We brought them together for a meeting that Tamara was able to fund through a CIHR grant. And this really just highlighted that pretty much everyone, for a large degree, thought it was very important to have advanced care planning discussions. For the most part, they felt that it wasn't feasible. So that gave us some helpful information as we moved forward. Tamara led a scoping review, searched the literature and the gray literature to see what tools existed out there. Through a screening process, found 32, and then a more detailed screening ended up with 4 tools that she felt would be the most well-developed and applicable for long-term care. Some of these may be familiar to some of you. Eventually, we landed on the Conversation Starter Kit. This was one that our homes highly endorsed, as well as our stakeholder group. It's one that was developed in the US, so of course we knew we would have to adapt it for a Canadian population, and certainly for Ontario with our laws in Ontario. So this takes us to where we are now with our new advanced care planning, our iCAN ACP project. We're using the Conversation Starter Kit tool and really taking it back to the homes and trying to get people's perceptions about what they think about it, and some of the barriers, again, to implementing this tool in long-term care. We'll be looking at the impact of implementing it. Again, we're targeting a different group in this study, so we're trying to target those that are early on in the trajectory as opposed to end of life. So we're targeting those where we can engage residents and families together to start talking about some of their values and wishes. And we're using the booklet, the Conversation Starter Kit booklet, to get families and residents engaged in these conversations very early on in long-term care. This is the definition that our iCAN ACP group landed on. Rebecca Sidori, I believe it's from a publication that she published. Some of the wording we changed a little bit, the medical term we changed to healthcare instead, given the high prevalence of nursing and allied health professionals, largely in long-term care. And we provided staff with some examples of advanced care planning. So this was something we felt was needed to help explain, what advanced care planning is, because we found out very early on they didn't understand what it involved. So we gave them some examples about what we feel, and it's in the literature, types of questions and conversations to have during advanced care planning discussions. So far we've collected our baseline data. We have 4 homes. We've done focus groups, interviews with pretty much every group that we could find. In this study, we actually accessed, one of our homes has a high public guardian and trustee population. So I believe about 70 to 80% of the residents were homeless before they entered long-term care. So what we found in our previous study, having family care conferences, it's hard to do when there's no family there. So we're now working with the public guardian to find out how we can help support these residents to ensure that they have an opportunity for advanced care planning, and that we respect their wishes and values at end of life. So we're still in the process of analyzing this data. We do have a staff survey that's out, and we should have all of the surveys back, I believe, in a couple of weeks, and then we can move on to doing that analysis as well. So current work, completing our baseline data collection. We are hoping, well, we do have the intervention, I believe, now formalized, and we'll be moving ahead with chart audit, data collection, and we're also bringing in a palliative expert to help us provide some education around advanced care planning and having difficult conversations with our long-term care staff. Right now we have that slotted for March, and after the education, we'll start enrolling residents and families into the study. So these are the, for those of you interested in the Conversation Starter Kit booklets, they are online through the Institute for Healthcare Improvement. They've been translated in multiple languages. We're focusing primarily on the dementia version, in part because that seems to be what we're seeing in long-term care, and it just seems to be a better fit. There are the 2 available, though. Okay, so I've come to the end of my slides. This is the opportunity I'd like to hear from others. I'm getting a bunch of questions coming through on my screen, and I'll try my best, I guess, to get through them. So I would suggest for those who still have questions or comments, if you type them in. I think I'm the only one who can speak, so I'll have to be the one to speak. If you have comments you would like to share, I can read them out. The first question here, what is the average length of stay for residents at the pilot long-term care sites? So what we found when we did our initial baseline data collection, we found about 27% of residents died over the course of a year. We did compare that data with national CIHI data. Interestingly enough, that it was 27% back in 2014, but the newer data I was just looking at for 2016 and 17, it's ranging between 32% to even 52% of residents dying over the past year. The challenge with that data is it does include, it's classified under residential care, so it will include people outside of long-term care as well. But that's the data that we were finding, about 27%. Second question, who attended a family care conference? Specifically, what was the rate of MRP physician attendance? Not 100% sure what MRP means. It could be medical director. If not, then please clarify what that term means. So we intended the family care conferences to be very interdisciplinary. We had hoped that we would get personal support workers and care aides, dietary, physio, nursing, physicians, everybody that we could. We ended up with about 80% being nurses. For the 40 family care conferences we held, we had physicians at 33% of those. We were a bit disappointed. We had hoped to get more physicians there, which we know is important in providing informed consent for families and residents, and to be able to provide the kind of information that families want. So our goal is really to reach out and try to engage physicians more in those family care conferences. So I think that may answer that question. Will this presentation be available online or sent to participants? Happy to do that. I will likely share it with Marilyn, and I'm not sure if Marilyn has a way to share it or post it. If you do want it, feel free to email me. I don't have my email address here. Oops. Let me just see if I can. Anyways, I'll just tell you my email address, kaasal@mcmaster.ca. Feel free to email me and I can share slides, resources, links, whatever people would be interested in seeing. I'm having a hard time seeing if there's any other questions down here. It looks like, oh, where can I find the 4 tools that came for the systematic literature review? So we can, I'm just trying to think. Most of them are online. So the Speak Up, you can get through the CHPCA website. If you just Google Speak Up Advanced Care Planning, you'll find it. There's an Ontario-specific Speak Up version, and then there's, I'm not sure if each province has their own version, but I know there's different versions depending on which province. The Conversation Starter Kit, as I mentioned, is online through CIHI. I believe if you just Google these, you will likely find them. The Go Wish card game, it's accessible online through a website from California. If you have a hard time locating that, again, feel free to email me. You can buy the cards. I've purchased a couple decks. They're not cheap, but there is an online version of the Go Wish card game that is free to use. So hopefully that's helpful for you to access them. Can you share the links from your presentation? Any plans to develop local resources for BC? So again, those, once we share the presentation, you'll have access to those links. We just checked them, they're still functional, so you should be able to access them through the slides. And we're working with Susan Brown in BC right now. She has the pamphlets, and I believe she's working with a group within her region to adapt them for BC. So they are, yes, they should be ready hopefully in a month or so. We also have someone in Yellowknife adapting them for Yellowknife, trying to make them more kind of regionally helpful. How many residents died within 6 months who had PPS of more than 50%? That's a great question. We didn't actually track that. I could probably go back to my data and look at it. It was timelines were tricky to work with our original study, partly because the homes, we're working with them to try to get the intervention up and running. So some of the PPS scores were actually a bit older by the time we had the family care conferences, but we can track that. Generally, and we focus primarily on the ones that were under 50% because that's the cohort for our first study that we're interested in. For the new iCAN ACP study, we're actually focusing more so on those above 50%. So hopefully in a year or two, I'll be able to answer your question with that study. Okay, thank you. Thank you. MRP is most responsible attending physician. Okay, so the attending physician. So those, how I answered that question, it was really, for the family care conferences, it was the attending physician who attended the family care conference. And now, or in these homes anyways, we have less family doctors than we used to have in a long-term care home. When I worked back in early 2000s, sometimes we would have 12 to 15 physicians caring for all the residents for a 120-bed long-term care home. But I think now the trend is to have less physicians, 2, 3. So it's more of the physicians, for one thing, you see them more in the long-term care homes, and they develop a better relationship with the residents. Yep, so we definitely need to share the slides and the links, Marilyn, getting lots of requests for that. Next question, are you looking at the impact of SPA long-term care on health resource use? So incidence of transfers of residents from long-term care to hospital. Yes, we did do that in our original study, which you reminded me I didn't report on. I do have a slide that shows that. So we did have a decrease, albeit minor decrease, in ER transfers, hospital deaths, and hospital admissions, and an increase in planned hospital transfers as opposed to unplanned hospital transfers. So there was a trend for improvement, but they weren't statistically significant differences. So it's a matter of 66% being transferred to the ER, or maybe not that high, closer to 50%, and a drop of 5 or 6% after we implemented the intervention. So not a huge change, but certainly a positive change. Did you consider looking at any RI outcomes, chest scale? Yes, we did. And in fact, our next study, that's what we're using, is the MDS-RI chest score in order to kind of target residents for our study. Great question. It's, pros and cons to all of these. I can honestly say there's not one tool that I would say is perfect. The RI is great in that homes already have to complete it, so it's less burden on homes to complete it. The downside is, it only gets completed generally every 3 months, where the palliative performance scale is something once we had it integrated into these homes, personal support workers or care aides didn't even need to actually have the tool. They would just say, okay, they would see the resident and just in their head say, they're at a 40%. So there's pros and cons. I think maybe a hybrid of the two might be good, or maybe, look at developing a new one. I know the other one that I'm interested in is the SPICT tool that was developed in the UK and Scotland, and it's actually, it has some of the components of a PPS where it looks at functional decline, and it has kind of condition-specific indicators of decline, and also includes the surprise question. So would you be surprised if this resident died within 6 months? So that's another tool that I'm quite interested in, and I know some of you probably are using that tool. It's from the UK and being used widely there. Great. Well, we're at 12:58 and good timing. I've reached to the thank yous in the comment section. So it looks like I've managed to get through the questions as well on time. So Marilyn will be happy with me. Okay, thank you everyone for joining. We will work our very hardest to get the slides and the links to everyone. But again, if something happens and we're not able to do that, please feel free to email me or tomorrow. We both would be very willing to share whatever we can with you. Thank you.